I'm going to show you how I built a Class 2 bimaxillary protrusion case with a tongue thrust. Extrusion movements are one of the most unpredictable movements. Secondly, I'm going to prove to you that you cannot touch a patient without an X-ray as a tool when you do your treatment planning. This is one of those cases that the clinical execution is almost more important than an optimized treatment plan. This case, I've done the first setup, sent it to the dentist, but I needed more information. I hadn't had enough. I requested a submission form with all the detail about what they want to do, what they want to achieve, and how they want to achieve it. And secondly, for me, I needed X-rays, preferably a CBCT, and I was very lucky to receive one. And I'm going to show you guys how important it is. I wish we could do every case with a CBCT. But over time, you develop an intuition onto which cases you really need this. And I'm so glad I requested one for this patient. So let's have a look. I've done the setup. Let's go through the movements. Anterior open bite. I've asked the dentist about the tongue habit, and I couldn't get lots of information. For me, it is so important. It doesn't help you move teeth to a position and a habit, muscle, or occlusal forces is just going to cause relapse. So, but I'm going to write it in my summary to her that this treatment result is not guaranteed unless the muscle habit is broken. Well, she mentioned some sort of, yeah, she thinks, but she's not sure about this. Okay, so let's run through the movements. Closing the bite. Let's go through it again. So it is a lot of upper extrusion. I extruded the laterals more than the centrals, and I think it was because they're very small, and extrusion is, personally for me, intrusion and extrusion are the most difficult movements, the least predictable. So I over-extruded to make sure that we at least get the amount that we need. The other thing is to leave space for restorative work afterwards, because this is also an aesthetic case. Let's see the amount of extrusion, 2.72, and it is red. This is a huge amount. Doesn't mean it can't happen, but you have to be careful if you do that. 1.16, 1.86, 2.69. I remember, I showed her the difference if you don't go into the red when we had a discussion. So in reality, to give her a smile curve, I would have liked to do something like that, but you end up with 3.5 millimeter of extrusion that you need. Let's see in the bottom. Also some extrusion, and the two centrals the most. At least it's 0.8 and 0.54 is not that drastically. Okay, let's check the movements from occlusal. It's minimal mesiodistal movements. I see rotation of that canine. Rotation is also a movement that's sometimes unpredictable. And the longer I'm doing my own patients and I see the cases that comes back for us for matching, canines are teeth that takes a long time to move. And they're round, you've got very little hold on them, and they've got massive roots. So what we have is a setting where we can adjust the global settings, and here we have the values which goes into each stage. So when you talk one stage or one aligner gives you 1.2 millimeters of torque on it. Angulation 2.5, rotation 2 degrees, And I've made this less. Intrusion and extrusion is 0.15 and 0.15. Translation, that's like mesiodistal movement, bodily, where the whole root and the crown moves together, 0.25. So torque, 0.2. Angulation, this is a angulation for all teeth. It all depends on which tooth you are trying to change the angulation. Some are easier, some are more difficult. And it also depends on with what other movements it is combined, or if is it over a distance that you're trying to change the inclination. So normally I will leave the inclination at 2.5, and when I evaluate the movements at the end, I will check it out. Rotation 2 degrees, again, it depends on the tooth, which it is, and I will slow it down in my staging. And as I said, extrusion, intrusion 0.12, and translation 0.25. So I've already made it less. That's the standard on which I work for extrusion and intrusion, and I'm happy to see that I've made it less. Okay, so the canine is rotating. And before I start looking at the collisions and the staging here, I have to go back to the final positions. And now, looking at what we have here, let's just quickly, interdigitation is good, it's not bad. It's going to be an implant, most probably another implant there. Personally, I don't think that's enough space for a crown there. So one would want to do some intrusion there. And but what I guys want to show you guys as well is, if we go to the start of the treatment and we look at the inclination of the teeth, let's remove the gums. Okay, so this setup hasn't been done with the CBCT. These roots are just drawn in according to the crown, the size and shape, anatomy of the crown. So it is not real time, it's an animation. And so it's determined by the crown shape. But the important thing is, although you don't have the real roots, you can follow what you're doing with the roots. You can see where you are taking the roots. And that's important to be able to compare it with what you have and in which direction and up and down, where are you taking that root. And let's maybe do that. For me, just looking at this, looking at that 4 there, and you look at that buccal, the line of that crown there, this makes the root, which I don't agree with that. I would want the root to go much further out. And we can go and have a look. Let's see. Here we've got a CBCT, and let's go to the sagittal view. And we go to the back. Sorry, let's just first, no, not sagittal, coronal, axial. It's loaded and no, it's not what I want, sorry. Coronal, there we go. If we look, there we've got the 6s in, maxillary 6s, 7s in the bottom. Then we move into the dentalis area in the first quadrant, and now we get into the 5 has been extracted on the CBCT, still present with its periapical area. And then we go into the 4. No, sorry, that was backwards. So look at that. That's a 5. And there we have the 4. Also already a root canal treatment on it. And this is totally a wrong inclination. Teeth needs to be, as I've said, in the trough of bone with an angulation with the root out. So that crown have to come outward. Look at this premolar here, the angulation there and there. And any forces on this tooth is pushing it in the wrong direction. So let's just see where that one goes. 5, the double root, and going forward now we're hitting the canine, so that must be the 4 and the 5 on this side. Again, that inclination wrong. It should be, it needs root torque. When the root moves towards the palate, it is root torque in the stricter sense of root torque. Okay, so let's go back to our setup. So that's the truth that I said. I don't like the root, and just look at it there, and it has changed, but not enough. So I'm going to give it so much more torque, and even the canine. That one is maybe, let's see what it looked like when we started. It's a change. That canine can change a lot as well. Canine change as well. And going back to the decom. No, come on, sorry. There we go. Well, we've got this here. Look at the inclination of the bottom teeth. That is correct. It should be like that in the upper teeth, in the same direction, to get the force of the occlusion through the long axis of both teeth. Okay, let me just find the right way to go. There's the wrong one, so I need to go back to that side. Look at the molar. And although it looks good, but then I look at this position of the roots, and then I will look at it here, and I will make sure that I get a balance between that surface, that surface, that surface. So looking at that, I think I should add a little bit more torque there. Okay, so let's see what happened on this side. That one needs more. That one may be less intrusion. And I haven't got a want your smile curve to be even, and then you have to go up there, so that one needs to come down to complete the curve. What do we have here? That tooth needs to change slightly. Maybe come down a bit, and then we okay, so now I've moved them a lot. I need to check, and I can see I'm totally out of symmetry here. I've added lots of movements here, so let's just get it more or less. I took away the settings here. Let me get that back. Collisions, attachments, initial scan. Okay, so let's see what we have here. But before I start utilizing these spaces, closing and opening up, I need to get symmetry on this arch. So let's just No, sorry, that's, yeah, grit. No, it's 0.5, I want it. And let's have a look. Line the midline up, and then I can start seeing my lateral. This one is not as symmetric to that one. There I've got a bit more symmetry. I've got a 0.6 midline that's off. The dentist asked me to keep the midline where it is, so I can got space both sides. So I'm going to go. Space is gone, and there we go. Okay, but this canine is touching there, so I need to it's too much. Lying in that block there, lying in that block. So this 4, I can go more out with this 4, trying to create symmetry here, but the 4 is, let's just move that canine there. So these canines are both on that line. That's not a good contact point, so let's fix that. A quick interruption. If you found the content of this video helpful this far, please give it a thumbs up and make sure to subscribe to my channel for more content just like this. Okay, so let's close these spaces. Not good. And the shape of this 7 on the visual is not normal. I don't know what we have there, if it's a filling or, so I'm going to have to go back and see what's going on there. It seems to me like this patient previously had aligners with that flat surfaces. It's so typically of interproximal stripping. And then we have this contact point here, which is not good. That may be part of the pre-processing steps, which I'll have to ask the technician to go back and have a look at that and fix that for me. I'm not sure. This is not going to be an anatomically good contact point for this patient. Food impaction, no, the food is going to get in there and stuck just because of flat surfaces. And then I need to check that movement is just buccal movement. That's not too difficult. Okay, so let's go back there and back to our grit, centrals, canines. Okay, so that 4 is quite lined up, the 5 and the 6 is missing, so the 7, similar to this one. And it is, let's just get it on the midline. So it's 1, 2, 3, 4. 1, 2, 3, 4. There we go. We've got relative symmetry, but now I'm going to have to close this space. Let me first check. That's why it looks so funny. We take the gums away, we can see that this canine needs to be extruded a lot, and then it's going to need more space again. Because your contact point is always at the highest contour, which is then there. So let's get that root slightly back, and now we can bring it forward. Close the space. This root is very far back. Where have it been? It's moved up a lot. We look at the roots once we've closed up all these gaps. So let's just, now this looks really, just get that symmetrical. It tricks my eye if it's not symmetrical. And then again, the contact points indicate to me that that canine should come off, come down. And again, the contact points show to me that the inclination isn't good. 0.5, 0.5, I can easily just close that up. There we go. And that again, I thought the contact points looked good, but it's not, I didn't check it. So let's just get that one down. Actually, yeah, it's not too bad. I'm a bit concerned because there's a lot of hard contacts on this, and we're going to have to sort that out. So let's see. With the open bite, she's got contacts on the 7s and then a little bit on the 4s, hardly anything on the 3s, obviously. As we run through, the contact points increase, become tremendously hard. Gonna have to work on that. But first, the root position. So okay, now we have to make the bottom fit. As I said, there are hard contacts, so let's see what happened. Extrusion on the front one, so I can make that slightly less. Let's get the contacts back. But it was an open bite, so you're going to add more contacts than you would have in a normal case. This looked like a occlusion, a transverse discrepancy, so let's see. Okay, so it's not. The position of this cusp between the two, between the 4 and the 5 is good. But the contacts are hard, so I'm going to have to see what I'm going to do. I am going to intrude slightly. That's maybe not slightly. But I can see there's a marginal ridge height difference, so that's definitely playing a role there. And this also gives me better contacts there. But now I have to, I'm first going to remove all of this. I just hate, always hate. If I don't need to do it, I'll do it eventually if I can't otherwise. If there's a Bolton discrepancy, anything that forces me to do that, and that I'll do at the end. Okay, all of that gone, so let's see. Dentist asked me to maintain the upper midline, so which means that I actually should go distal here, which is not going to work. I have to go in with that one. So together these are almost the same, so it's not really a discrepancy in the size there. Okay, I'm going to have to close it to this side. Rotation, difficult movement, difficult. Again, looks like interproximal stripping that has been done there, not in a good way. I can't say she had, but I think she definitely, she had previous aligner treatment, and that's one of the reasons why I don't want to do stripping. We blow it up here, but you don't, in the mouth you don't see it, and then you don't end up with this. Okay. Okay, not a good position there. Improve the contact. But before one really do all these small minor movements, first just check the relationships, because any move now changes that. Like for instance this, I made it symmetric with the other side, so I can't bring this in, so I'm going to have to bring this out. And change the root. It always helps to get it in a better position. There we go. And that tooth bugs me. Can come in slightly and still be symmetric, maybe not that much, but that is like, that's 5 millimeters, that's 1 millimeter less. So let's look at the right hand side. Okay. Why I also like chalking the roots in, I get just so much better overbite here for these teeth. Can't really go forward to close that, and then I'm out of that stable position for that cusp there. So for the time being, let's leave it there because there's still some movements which may change that. This is not good. The buccal surface there must be parallel to that one, and that one is too much. So I'm going to have to bring it back, which then, yeah, that's not bad. That looks good. Still not parallel. I think I'm going to do a little bit more on that one. I think this patient have passive delayed eruption. The reason for that is that it's passive delayed. Her tongue is in between the teeth. It prevents the teeth from growing down. So it delays the eruption of the tooth. It's a force against the moving down of the tooth. But the bone's still growing down and the gums come along with it. And then the bone covers the CEJ. And then you've got a shorter crown. And because of the bone covering the enamel part, it is a thicker, actually unsightly type of periodontium that you get. So if you take that patient and you do a crown lengthening procedure, which exposes more crown, which makes it more beautiful, and I don't know if it's necessarily easier to clean, but it exposes more crown and it improves the quality of the gingiva aesthetically, definitely. And yeah, you've got bigger teeth. It's beautiful. The patients love it. So we're going to pull them down. Most of the cases when I've got delayed passive eruption, I would do the crown lengthening before I do my aligners. The patients just love the improvement of the aesthetics, and I get a bigger tooth surface to work on with my aligners. But in her case, where we are going to extrude the teeth to close the bite, the teeth are going to come down, and normally your bone and your gums takes longer to react, to grow along with the tooth. So in this case, we may actually resolve the delayed passive eruption just by bringing the teeth down. So this is more or less the final position of the teeth. I have to look at the staging, just get all the teeth to move. And then we've got, that's the 4342. That's too big a space. Okay, let's see. 1, 2, 1, 1. I've got 0.14 that I can use, so I need to get this tooth. But in the final position, there is not a collision. So again, I can just take the red as danger. Teeth are going to collide, they're not going to move. Blue, beautiful. You want spacing around the teeth. It helps you so much to get the teeth to move, especially like this canine that needs to rotate. But we've got a lot of movement, tooth space there, so I've closed it all up. I can, let's see if I move this down. To delay the movement of the 1-1. Yes, there we go. Without going into detail, let's see what happens in the bottom. Between the 3-2, 3-3, we've got a collision. So we can let the 2-2, the 3-2 delay its movement. There it's gone, and then that collision there. Four, 2, 4, 3. If possible, I can speed up the movement of 4, 3. No, I can't. See if I can delay this one, and this one, and that one, and then I'm out of collisions. Now we get to an important part. With this case, I've told you guys I've asked for the CBCT, and I need to look at, but let's just maybe quickly check what happens with these roots, because I'm now going to the roots and the CBCT. So let's see. Expansion and a lot of change in the root here. So the blue is where we started off, white is where we're moving towards. And let's have a look at the patient's CBCT. That is the 1-3, that one there, that's a 1. Let's just quickly check. Yeah, that's a 1-5 that has been extracted. The 1-4 is in the mouth, and then we're into the 1-3. And I have a huge concern. This root needs to come in. And let's see what we did with our movements. Back at the upper. 1-3. Yes, we brought it in. And that's the point that I told you guys. This torque, the root needs a lot of torque. So that one went in. Okay, let's check the next one. Then I have to check with the axial. So let's go on. Canine needs to come in a lot. Now we're into the lateral. It's sort of safe, it seems to be. Now we're into the central. The central's root is totally in the bone. And we have to be very careful how we're moving the central. We don't want to cause root resorption. So let's see what happens with the central. In actual fact, the roots does go back. Let's just check. It looks from that point to that point, if it comes forward, it does slightly. So that is a concern. It's not. The canine comes in, that one comes in. But I would like to have on the central, lateral, central, lateral, central, central, and lateral. lateral. See this central lateral, the root comes forward even more. That is, it's going to cause a lot of trouble. So let's just see what's going on there. Back. I want you back. I want you back. Away from the bone. Long circle. Back. And now I can see the blue is where the root apices and this part of the root was touching the cortical bone. And now they're all back. Okay, there we go. Now, this is now for the final position. The teeth are the root apices we took out of the cortex. Let me just fix this. But what he did, just double check again. Okay, I want to see the path of these centrals coming down because it's, as I said, 3.6 millimeter of extrusion happening there. And although in the setup, which is an animation, the root goes further back, we have to be aware of the biomechanics of the forces playing out on this tooth. So firstly, we have a tooth crown and we have the root. The rotation middle point of a tooth is 2/3 up into the bone, so it's going to be here. So if you want to move this tooth bodily and you're pushing it back, the root is covered with bone. It's going to rotate around that point. Even if you program in bodily movement here, it is going to rotate because the resistance there is more than this side. Now it's rotating around that point, you're going back. What happens, that part of the root is coming forward. And this is not shown on the computer screen. So you have to work this out on yourself. So I need to check and see, yes, those teeth come back. So I am going to have roots that actually comes forward, not going to be there where they are. So I have to compensate for that and add more root movement there. Secondly, if while we're doing extrusion, aligners push, they don't pull. So you need to see on which surface they can push, which surface gets the biggest force, and that is a surface 90 degrees to the aligner where you want to push. Now looking at this teeth here, that is where they are. You want to have that tooth go down. You're pushing there, but there's no force, there's nothing grip on this tooth in a direction that you want to have your force going. So this gives you the biggest force on the tooth, but we don't want it to go there. So we need something to push down. Now, what I do with my cases, I always put in additional proclination and I add an attachment beveled attachment. That gives me a lot of hold on the tooth to extrude. But now, if the attachment surface is like that, and you push there, it's going to push not only down, but there's a vertical force of component which is going to push it in. And you have to supply, you have to make sure that you've got enough space for the tooth which is going to come back, and you have to look at the roots again, which is going to come forward. So we've got double compensation that we need to apply in these roots to make sure that they don't hit the cortex. If the tooth hits the cortex, or is in the cortex as it is, one of three things can happen. Either the root resorbs, and I've seen many cases like that, or the root goes through the bone and you get a pulsating periapical root there in the buccal sulcus. Or you get, what is this, the third one? The root resorbs, the crown, okay. If the root is in the cortex or touch the cortex, there's one of three things that can happen. Either the root goes through the cortex and you get an apex in the sulcus and it's pulsating. You can literally, the patient will tell you it's there. It has happened with me. Secondly, the root will rub against the bone. If it doesn't go through, it's going to resorb. The cementum covering the tooth is much softer than the bone, so you get root resorption. And the third one, there's just no movement. That tooth is stuck in the bone, and you try your best to get somewhere with the tooth, and you're not going anywhere. So this is a case where I would, if it was my patient, and I will advise the dentist, that continuous CBCT recordings to see what happens with the roots is important. And then she can overlay, she can check, and we have to monitor those roots to make sure that there's nothing that goes wrong there. But now, the problem is I need to add those root movements to compensate for the anchorage that the bone creates. By doing that, the teeth are going to literally look like that, which is a weird look on the animation. And dentists and orthodontists use this to teach their patients, or not to teach them, to inform them what it's going to look like. And I'm going to overcompensate, so it's going to look weird. It's always a problem for me. So what I personally do when I have a discussion with a patient, I will move my slide to till where that looks good. But that extra compensation, I will just not move the slider and see if I can at least give them an idea of what it is going to look like. Okay, but what I saw when I was looking from the top, it just doesn't seem symmetrically. And yeah, that root is further back. So let's just get that one is further back. And I don't mind to go rather further back than too much than too little. There we've got that. And we've got a 0.2, which is fine. It's right at the end. We can actually do that. It's most probably going to go away. I will eventually move that one off as well. So 2 to 2 are these long movements. The canines also extrude over a long period. So I will extend the movement as well to the bottom. Now I've got a collision, so let's see where we get rid of that. There we go. And let's see if I can. Here we go. Now I'm more happy with the type of movements. The final positions, there we're going to get a patient hitting on the front teeth. So it's always important to check, to run through your no contact on the front teeth, no contact, and there it starts hitting on the maxillary and mandibular central incisors, and it improves and it improves. If I go back to that point there, no contacts, and I carry on in the movement, it starts increasing there, and let's see what we have here. At aligner number 13, that may be uncomfortable to the patient, that contact point there. So that's going to take me to the bottom on aligner 13 and the central teeth 4-1 and 3-1. See if I can delay their movement to prevent that. And let's go back to contacts, and let's go back to 13. It's still there. (22) in the lower 21. If I look at the changes there, it stays the same intensity of contact, whether it just moves down the slope as they come in. So I'm going to take it back where I had them. Go back to 13. There I've got hard contacts. Let's just check that out. I'm going to have to make changes on the 7s as well as the 4 and the 3 there. Here's the 2 that wasn't properly in the scan. Let's see what's the problem there. Yeah, partially erupted tooth. Okay, no movement there, so that's fine. This tooth comes forward, so that's okay movement, not too difficult. We're going to have to do attachments for it. And those hard contacts needs to be sorted. No, it's distalization. It moves back 3 millimeters, which is quite a lot. There's movement programmed onto this 6 year. Let's just go there. Sorry, the 1-7. Being the last tooth in the arch, no teeth here to anchor, just a small piece of plastic running there. It's going to be very prone to breakage there. I just feel like this tooth, rather than building in something that's not going to work and the patient is going to break that, to get predictability, I'm just going to see if I take the 1/7 and I remove all movements on it. How bad is the bite going to be there? Okay, there may be problems with the movement there.